So, so Professor Chandra is really one of the more remarkable people that you're going to meet in neurosurgery. And, I've gotten to know him quite well in the last many years through through the International Epilepsy Surgical Society that we've both helped form together, through the International League Against Epilepsy. As I was just saying a minute ago, he and his wife form a combined neurosurgical neurology power couple in epilepsy. They wrote the seminal paper in New England Journal on management of pediatric epilepsy, epilepsy surgery a few years ago. But I didn't actually realize, because I know his epilepsy accomplishments so well. And they standalone are probably more than anybody else has done in the last 10 to 20 years in epilepsy. But then looking more, he trained at NIMHANS in Bangalore, which is probably the most famous neuroscience institute and hospital in southern India. And now he's the chair at AIMS in New Delhi, which is the opposite in northern India. And he's done over 25,000 surgeries as an attending. And beyond epilepsy, he's been president of the Skull-Based Society in India. He's been president of the Cerebrovascular Society in India. And he's made seminal contributions to spine surgery there also. So in kind of the old school, somebody who really across the gamut of neurosurgery has incredible breadth and talent. But besides just running a major department and doing 25,000 surgeries, he's always thinking about, okay, how do we make this simpler, safer, better? Particularly in what hopefully I think he's going to talk about, but maybe not just epilepsy, but in my world, he has creatively thought up and really originated changing care for pediatric epilepsy. And you see a lot of people going to visit him specifically to learn the way that he is doing things, because he's doing them differently than anybody else on the planet right now. And when somebody's doing something different from everybody, I always say to the residents, when you think up something different, you're either really smart or really stupid. Because if you're doing something that no one else has ever done before, either you thought something poorly or you thought out of the box creatively. And Sarat is the guy who's been thinking out of the box and advancing care. And I think it's fascinating and amazing to see what he's done. And so he's going to talk to us today about the science and art of finding new cheese. And there couldn't be a better person to talk about this topic. So Sarat, thank you so much for joining us.
Thank you so much, Guy McCann. Give me a few minutes to share my slides. Thank you. Thank you so much for that kind introduction, Guy. It's always a pleasure hearing from you. I mean, the way you express yourself, the way you speak, and the way you present. There's a lot of stuff which I really learned from you. And for me, it's a great honor to be doing this grand rounds here. And at the outset, good morning to all the faculty, students, and fellows. It's truly a great honor and pleasure for having an opportunity to conduct this grand rounds here. And I'm truly grateful for that same, and especially to my friend Guy McCann. And you may find the topic a bit different, but it would become clear as I speak more about it. It's more of a philosophical journey which I've undertaken 25 years and speaks about an overview about what has been my line of thinking despite being in a very busy practice. The paradox is that if you're very busy, you don't have time. If you're not too busy, you don't have the scope for developing something new. So somewhere you have to strike a middle ground. And let me advance my slides. So we are here. This is where this is the All India Institute. So as per today's paradigm of shrinking globe, we are just 14 hours away from New York. So all of you are welcome to come anytime to All India Institute of Medical Sciences, and we'll love to have you here. And this building, which you see, is called as a Red Building. It's called as a Cardio Neurosciences Center. It's one of the oldest departments of the country, established on 1st March 1935. And we recently celebrated the 60th year. We have about 7 ORs for elective and 2 ORs for trauma. We have a gamma knife. From the epilepsy perspective, we have magnetoencephalography, PET, SPECT, and 10 EMU stations for video AGs. We do about 5,000 to 6,000 cases a year. It varies. and approximately 200 epilepsy surgeries a year. So it's customary for any oration or for any grand rounds to acknowledge the people because of whom you have been here. And I've been standing on shoulders of many people. Rather, I've also been pulled from the top as well as pushed from bottom. So there are a lot of people who are responsible for where I am there today. Professor Tandon and Professor Banerjee are the founders of our department. They are my mentors and my teachers. They are amazing people. So Professor Tandon is 97 and Professor Banerjee is 90 plus. They're hale and hearty, absolutely sharp in their thinking. God bless them. Professor Tandon is one of the few neurosurgeons from India who trained directly under Professor Wilder Penfield as well as Professor Rasmussen. And Professor Banerjee is no less. But one of the best things what I found about them is that despite them being very well established in their own fields, they managed to keep the relationships very good. So there's a saying in India that if your parents are kind to each other, your children will also be kind to themselves. You don't have to do anything. So even today, they visit each other once every week at least, even though they find difficult. And that has set up quite an example for us. I would like to acknowledge Professor Gary Mathern, under whose mentorship I've done my postdoc fellowship at UCLA. And what is remarkable about him is that what I learned especially was that he had his own neurobiology lab, which neurosurgeons in India do not have. And that has really encouraged me to build my own neurobiology epilepsy lab. And I learned a lot of things from him, especially in terms of research methodology. He's really quite sharp in those aspects. I'd like to acknowledge Professor Mehta, who was a chair when I joined the department after my training in NIMHANS, Professor B.S. Sharma, Professor A.K. Mahapatra, who were later chairs. So even though I was not directly the student, but they have been equivalent to my mentors and my teachers. And I have learned a lot of them, and they were really very kind and nice to me. My introduction would not be complete if I do not mention the teachers under whom I have trained, Professor B.S. Das and Professor Chandramurli. And I'm very glad to see that Professor Chandramurli is here, and the late Professor B.S. Das, unfortunately, is no more there, and Professor Shastri, of course, is here. And what was good about these three people were they had excellent relationships, and that set a very good platform for learning. And even though Professor B.S. Das was a brilliant neurosurgeon, but one of his most famous quotes, he was fundamentally a very good human being. And one of his most famous quotes, when anybody would ask him about career options, he would say, "Why don't you try to be a good human being? There is very little competition in this area." I understand I am addressing a department of glorious legacy, and I'm really honored to state that none other than Professor Charles Ellsberg has founded this department. And along with the trio of neurosurgery, Professor Harvey Cushing, Professor Charles Frazier, and Professor Sachs, they have founded the Society of Neurological Surgeons. For me, it's really a great honor and also a bit of apprehension, because I would try my best to keep up that reputation on the pedestal on which I have been placed here. I would like to acknowledge my family, my parents. My father, unfortunately, is no more. My wife, who's been very steadfast, not only in the work front, but in the personal front. Our children. In India, when we speak of family, it doesn't mean your wife and kids. It means those lot of people around you, because we are quite well networked. And of course, we also thank a lot of gods. We have a lot of them. We believe that without their help, we don't progress anywhere. So I would start this grand rounds with this story. I'm sure many of you would have read this book, but this was one of the books which really influenced me. For those of you who have not read this, it's a very small book. You could read it. You would finish them in about 1 or 2 hours. So it's fundamentally about four people, two mice and two Lilliputians, who would come every day at 9 a.m. They would eat the cheese in a hypothetical cheese station, do their work, and go back to home by 5 p.m. And soon they started thinking that the cheese would last forever. So it sounds familiar. And so one day what happens is that the cheese runs out of the cheese station, and it fundamentally the different personalities of all these people on how they would react when the cheese runs out. So Sniff and Scurry are mice. They have absolutely, they function without any kind of inhibition from the limbic or from the frontal lobes, and they immediately set out in search for the new cheese. Now Hem stays back. He says, "It's not fair. I'm going to stay here the cheese has to come back. I'm going to appeal to the unions and so on. But How stays for some time, is afraid, but then he slowly starts venturing out and then starts his journey to find new cheese. I somehow associate myself with how that, and most of us, because when we are faced with challenges, we do have a certain period where we are afraid to venture out into something new, but then we conquer our fears and then go across. And this is precisely what this journey is about. So I always have this uncomfortable feeling to always stick to the comfort zone. And if you look at the famous split brain experiments done by Professor Sperry, who did it in patients with corpus callosotomy, he exposed the patients to different visual paradigms to different hemispheres. And the patient ended up telling a combination which was totally fictitious. So based on this, masters of psychologists have created something called as a narrative self. So they say that based on very few experiences, we weave stories around ourselves, which creates the narrative selves. And most of these stories are actually fictitious. And one of the stories is that it's not possible to do more here. So that's one of the most dangerous stories, and it's a fictitious story. And I have been struggling to break out of this paradigm my whole life. And this is a journey to show that from where you are there comfortable in a job and you would rather not do anything at all, to move to do something. So this was in 2000 when I joined freshly as a faculty at All India Institute. And then I would do a lot of carpal tunnel, being one of the junior faculty. And of course, we would also get some major cases. And then I had this idea of developing a disposable endoscopic carpal tunnel, which I did actually. We published a paper, we spoke to a company who did bring it to come, but it never worked out. But it gave us an idea on how you could actually go ahead and do something new. And that was the beginning point for me. And that's when I would do a lot of craniovertebral junction anomalies. Now, our center forms the referral center for craniovertebral junction. So when I joined as faculty, the faculty who would do the craniovertebral junction left the institute. And that is when, I was asked if I was interested in it. And then I would end up doing maybe 2 or 3 cases a week. So all these cases would require a transoral followed by a posterior fixation. And initially I would do it in 2 separate sittings. And then I started doing them in the same sitting. And about 20 years ago, I did the CT scan and I was really proud of it. But today I would not be proud of it, because I think it is possible to reduce this only from a posterior technique. So that's when we developed the technique of distraction, compression, and extension reduction. And it's based on the principle that you can put spacers between the OC1 and the C2, and it's used in conditions which are congenital craniovertebral junction. I know you don't see them too many in the US, but here in India, we see a lot. And in all these cases, the C1 arch is fused with the occiput. And in this case, I developed a technique where we can put a spacer between the OC1 and the C2, and then apply compressive forces between the OC1 and the C2 so that we are able to reduce not only the atlantoaxial dislocation, but also the basilar invagination. And based on that, we developed a universal reducer so that we could do all these complex techniques. So you can see again here, a very severe BI with compression through a posterior only technique. Again, we used a spacer as well as a universal reducer. You can see practically the spinal cord canal is absent here. And again, another example of a severe BI where we use the universal reducer. Another example, you can see that the dens is almost parallel to the ground with the spinal cord practically absent. And this patient actually came walking. So they have compression from such a long time that they don't completely develop quadriparesis. They are still able to, they have severe spasticity and they're able to walk with support. So these are some of the papers which we published. You could easily look it up. We have done more than 600 cases. And then we also did, one of my fellows, he did his PhDs and he did some work on FBN1 gene. And we found that most of these patients had mutations in FBN1 gene, which codes for Marfan syndrome. So we realized that we were actually dealing with a variation of Marfan syndrome, and we proposed a 2-hit hypothesis where we said that not only the joints are sloping, but there are also weakened ligaments, and both of them lead to formation of basilar invagination and atlantoaxial dislocation. So this is the new cheese. So this is what we do today. So if we get a case like this is what we would like to do. Use the technique of DCR, perhaps using the universal reducer to reduce it from the posterior technique. We used a variation of this technique to also reduce old undisplaced fractures of the dents. So what we do here is we drill out the C1 arch completely and put a spacer between the occiput and the C2, and then use it like a spacer and apply again compressive forces so as to reduce the AD. So you can see this 23-year-old female who sustained this injury 4 years back. And you can see that she has this horrible compression. And obviously, many people would say that you should do it first a transoral and then a posterior fixation. But using a variation of the technique of DCR, we were able to do it only from the posterior only approach. So this is another example where we use a posterior approach and reduced it from the posterior part. So these are some of my other innovations which I have done, small in their own way, but I believe they did have a significant impact on patient management. So when doing the pituitary surgeries, most often I felt that most of this equipment are just industry driven. So, and I never liked the manual technique. So that's where we developed this easy retractor, which is called as easy track, where we do a transseptal approach. So instead of going through the nasal cavity, we split the mucosa and we pass the retractor through the septum after reflecting the mucosa. And this is when it opens up, you just have to cut the thread. When it opens up, it fractures the septum to one side. And then you are able to see the sphenoid ridge in the midline. And you just pass the endoscope in the 12 o'clock position. So the endoscope is also protected. It doesn't get fogged. And it's very easy for your assistant to hold. And rest of the surgery becomes very easy and straightforward. And these retractors, unlike the speculums, are very dynamic and very soft and malleable retractors. You could easily position it from all the sides. And this is an example of a large pituitary, which we had to do it in 2 stages, but we could remove it. Then, of course, this is another innovation which we did. So again, we have these patients who have vertebral body hemangiomas who come with myelopathy. It's not very common, but again, we get because ours is a tertiary institute. And doing an open surgery is disastrous. I've done one of them and we lost almost 5 liters. So I did a corpectomy, we lost 5 liters of blood. And that's when I decided that this is not the proper technique to do it. And that's when I spoke to the head of neuroradiology who would do percutaneous injection of absolute alcohol. Because if you do contrast, if you do some kind of embolization, it would be quite expensive for our patients. And you know, absolute alcohol practically costs nothing. And he had a huge experience of it being absolutely safe, except for 2 issues. It can cause pathological fractures because once the tumor cells get killed, the whole bony lattice can compress and can crush by itself. And sometimes they can also have neurological worsening because of swelling of the tumor. So in order to overcome this, what we did is we did a single level fixation in the same set, and we injected absolute alcohol to prevent neurological deficits. And by injecting alcohol, we were able to prevent any kind of pathological fractures. And now we have a follow-up of more than 10 years, and these patients don't have a recurrence because I believe absolute alcohol even kills the tumor cells. So these are some of the papers. Now, this was published in the paper because this lady was paraplegic with 6 months term pregnancy, 7 months term pregnancy, and we did it in the lateral position. Her power improved completely. She delivered a healthy baby boy, and she was wife of a journalist. And they found it really, very fascinating that alcohol can actually cause tumors. And then we started having questions from patients that if they drink alcohol, will it prevent spine tumors? So we had to tell them it's nothing like that. So at this stage, when you're in your journey of finding new cheese, you suddenly wish that you could have come earlier because you realize that having cheese, new cheese, makes you feel happy. So when you go along the corridors, you keep on tasting the new bits of cheese. You really like it. So my friend Guy McCann wanted me to speak mostly on epilepsy. And my journey with epilepsy has been quite long, almost 25 years now. And I'm really fortunate enough to have a lot of co-travelers, many wise, some learners like me, and some really amazing. Now, this was a person whom we operated. He was highly obese. And now he's a marathon runner and he goes cycling, and he went to the Paris cycling where he could cycle almost 1800 kilometers. So that's him. So that shows the amount of determination. And then, of course, here we have another amazing person. So as we cruise along, this would be a story of how we have journeyed in our journey of epilepsy surgery. And when I took up epilepsy surgery almost 25 years ago, it was like a blue ocean. So for those of you who have read this book, blue ocean, these are metaphorical oceans. So blue ocean stands for areas. It's blue because there are no sharks and there is no blood spilt into the ocean, and there are less of competition. But then you have to create your own competition, you have to create your own market. Whereas red ocean, it's filled with sharks, that's why it's red. So few examples would be endoscopic skull base or spine. So there are a lot of people, but paradoxically people still like to go into red oceans. Now when I started epilepsy, it was completely blue ocean, because people had different ideas about epilepsy. So initially, the perception was something like this picture, which is by King Gustav Adolf over the Battle of Sweden. So if you look at this picture, he looks almost godly. He's holding a scepter and he's kind of completely controlling the entire war, and he just has to move his scepter and the whole armies are attacking the enemies. So that's the perception I had about epilepsy surgery when I started doing. And this is a kind of perception that I had, that I would learn more about the functioning of the brain. But the reality was the 2000 yard stare. This again is a painting by Tom Lear. And if you have to just look at the face of the soldier facing World War II, you don't have to look at the tank or the trees or the skies. You have to see the look of horror, because all he has heard about the front line proved to be wrong when he came face to face with the war and battle. So that's always there. That was kind of my reaction when I started doing epilepsy, because we just had a 16-channel electrocardiographic machine, just one video EG machine. We would do with the difficulty one temporal lobe surgery a month. There was no experience at all with hemispherotomy, multilobar resections, or invasive EEG. And again, we didn't have any other. And we also would hear neurologists saying to the patients, actually, that one of the worst things which could happen to a person with epilepsy is surgery. And this was one of the first cases I did, which I presented in a local conference. So when I operated it, I showed that this was a lesion, but I got most of the ECG spikes from this area. And I learned that the area of the lesion does not correspond to the ECG spikes. And that was a learning for me. So the first learning for me was, one of the first learnings was that the lesion does not correspond to the electrocardiography. And I realized that if you have to develop epilepsy surgery program, you really need to focus on it. And I learned that the quicker you let go of the old cheese, the sooner you will start enjoying the new cheese. So that is a risk which you need to take. The other issue with epilepsy surgery is one is not sure what works. So if you look at William Gover's, these are all the treatment paradigms which he suggested: trephination, cauterization, castration, and circumcision. He actually thought that circumcision was useful. And if you look at all the treatments which were available in those days for epilepsy, appendicectomy, colectomy, bloodletting hysterectomy, that was a question they would put, that do they really work? And if you look at results, while we may sometimes feel proud of it, 61% we may say that these patients are drug resistant, absolutely no improvement with drugs. So 61% improvement with class 1 with surgery. But at the same time, we have to realize, why is it not 100%? So are we missing something? So when we look at all the techniques, that's the question which would arise in my mind to that, do these all really work? Are we missing something? Why are we not 100% in all these techniques? And now, somewhat they start looking similar. And this point of time, I would sometimes feel that, we have actually bought a microwave oven, and we think that we think that we have actually purchased a television set. So that's when we decided to target for low hanging fruits. So we developed a protocol called as a Petri tool. where we could screen patients who would definitely benefit from epilepsy surgery at the outpatient itself. And that's how we could started screening, and then we started operating them. That increased the success rate of our surgeries like anything, and that brought reputation to our center. We also published the hierarchy for epilepsy surgery referral in India, and we suggested level 1 and level 2, because we feel that the level 1 centers should not tackle with the more complex cases, because early failures can bring about ill reputation to their center. So for many years, I struggled with the two issues, clarity and ease, thinking of what could be clarity and ease, especially in the area of epilepsy surgery and epilepsy. And that's where I read my daughter's book of poems on clarity and ease. And even though these things were in mind, but when I read them, they became clear. So I would like to read it here. So clarity is not always clear blue skies, crystal waters that showcase the rich life contained in them. It's not always a spotless plan to be executed for days to come. It's sometimes realizing that even here in the messiness and the murkiness, you're free to rest. You're allowed to not know what lies at the end of staircase and take it one step at a time. Now, easy it is to bend, confirm, freeze, and fit in. Easy it is to break open, fluid and free, to carve your own art and trust where it takes you. And it's important for all of us to choose our own easy. So in epilepsy surgery, I found both clarity and ease, because it gave me an opportunity to bond with my wife, both at work and home. We were able to create an excellent team, happy to get a great research team, and again, their wife and husband. We worked really hard to set up a tertiary epilepsy surgery center. And through epilepsy surgery, I found both clarity and ease. And by this time, we had this amazing trial by Weeb as well as Pete Engel, which has conclusively shown that surgery definitely benefits patients with drug-resistant epilepsy. And we then published our paper in the New England Journal of Medicine, where we showed a tenfold improvement in kids who undergo surgery as compared to them who undergo only medical therapy. And not only that, we showed that secondary outcomes in kids who do not undergo surgery immediately and undergo surgery after 1 year are definitely much more worse off than children who undergo surgery earlier. So it clearly showed that kids require surgery. They not only require surgery, but they have to get it done as early as possible in order to prevent epileptic encephalopathy. The other challenge was that the MRIs are often normal. And as neurosurgeons, we are not used looking at this kind of substrates, because particularly when you're neurosurgeons in this part of the country, the kind of lesions which you look at is acoustics or pituitaries or something which you can easily make out. So looking at scans, particularly with epilepsy substrates, requires again a different kind of training. And when we published this paper, we showed the factor which was most important for determining drug resistance was presence. The good outcome of surgery was presence of a structural cerebral abnormality and non-responsiveness to the first anti-seizure medication. And this is a kind of substrates which initially we were not very sure, but we realized that it's very important to find the substrates, because finding the substrates is very similar to Sutton's law. For those of you who know Sutton, Willie Sutton was a gentleman bank robber because he never killed anybody, and he would only rob banks. And he was asked once, even though he denies saying that, but that's a very famous statement, that he was asked that, why did you rob banks? And he said, that's where the money is. So we try to find a lesion because that is where the networks are. And certain laws also come into medicine, where you base your diagnosis on something which is more common and probable rather than on some rare diagnosis. And it's also come into utility in cost computing and bank management. Now over here, we also learned the technique of coming back, which means that when you do a more advanced investigations like a PET MRI fusion, and you find a large area of abnormality, this is of course the work which I did with Professor Gary Mather, you could always come back and then again find the substrate. Now, extending the technique of coming back, we learned even more when we started doing stereoelectroencephalography. For instance, this patient underwent 12 MRIs, all were reported normal. And then finally, we found that the CG discharges were coming from here. And when we showed it to the radiologist, here, And finally, when we resected it, the histology was type 1 FCD. And then finally he agreed, yes, it is very subtle. So since the time we have been doing SCEG, it has been a great learning experience because we have now become very sensitive to identify even those very subtle lesions, which we are sure even 5 years from now, we wouldn't have been able to diagnose. We never had a WADA. So we developed our own fMRI protocol for memory and language, and we have published quite a few papers on that. And it is very important in a center because we find that there is an average delay of 16 years. And we find that when you have a center for epilepsy, your pickup rate of MRIs are much more than what is done in centers which do not deal with epilepsy. So this helped us to advise other centers that if you do not tackle epilepsy, please send those patients to us. Because when we do MRIs, we have a different perspective of looking at the MRIs, and we have a different rates of making it positive, of converting an MRI negative to an MRI positive substrate. And again, if you look at this study of ours, you find that there's a significant difference on the diagnosis which was made in our center, which is the blue line here, versus centers outside, where you can see a significant difference between our centers and centers outside. And that's the reason that it's very important to develop a comprehensive epilepsy surgery team where everybody is involved in the diagnosis. So we found in a study that approximately 33% were aware that there existed surgery for epilepsy. And overall pickup rate in our center was 88% compared to those in the peripheral centers, which was 54%. And obviously these rates would even out over a period of time, but till the epilepsy surgery facilities also developed there. And easily missed pathologies were focal cortical dysplasias, which were picked up only in 17% of cases outside versus 80% in our center. So at this point, we realize that movement in a new direction helps you to find new chase. But when you go in a new direction, you have to work against the comfort zone. And that's where we realize that we are going to develop the following protocols. We would do acute electrocorticography as a workhorse. We would try to maximize non-invasive protocols because most of the patients have to pay money for the stereo electroencephalography. In some cases, the insurance companies do work out. We decided disconnections over resections, and we decided to develop various minimally invasive techniques. We would do a CG only with a very strong hypothesis, and we felt that it is very necessary to develop our own research platforms. So a few words about electrocorticography. So we learned Dr. Mathon's grading and we modified it, and we find it extremely useful, particularly for focal cortical dysplasias, looking at the preoperative grade versus postoperative grade. And it does give us a feeling of confidence when we find that following resection, the grade has improved almost to normal. We decided to maximize our non-invasive investigations because the peculiar paradox with us is that the federal government provides equipment, the expensive equipment, it doesn't expect to earn out of it. But most of the patients coming to us are socioeconomically compromised and they cannot spend much money on their own. So we developed our own MRI protocols, and these are some of our papers on MEG. And then, of course, this is a work which I did in UCLA. We found that whenever we do a multimodal fusion, the vantage point is increased significantly, and we are able to visualize the networks in a much more better perspective. Now, this was a seminal paper which we published, which was very useful for us, where we found that a concordance between PET and ictal SPECT, if present, provided much better outcomes for temporal lobe surgeries, and for some reason did not translate for extratemporal lobe surgeries, but did not translate for temporal lobe surgeries. And the same was also shown by other authors. So an example of a patient who was having 4 to 5 seizures per day, and seizures presenting in form of visual hallucinations. And when we did a PET MRI, MRI was absolutely normal, but PET showed an hypometabolism which corresponded with the MEG. And patient also had, when we visualized, we found this focal cortical dysplasia. And on electrocorticography, we found the typical spike and wave pattern. So we did a temporal lobectomy for mesial temporal sclerosis, hippocampal sclerosis, as well as resection of focal cortical dysplasia, which we could localize without doing a stereo electroencephalography. We started doing disconnections instead of resections, and that reduced our blood loss, particularly for pediatric patients. Now, we see a lot of patients who have perinatal insult with bilateral parieto-occipital gliosis, and we found that when we are able to localize it to one hemisphere and we are able to do a posterior quadrant resection, approximately 60 to 70% of these patients, they become seizure-free. Now, obviously, because of lack of time, I will not show this video, but it's there on the net. We then created strategies for minimally invasive surgery. So these are the two techniques which we developed totally on our own: endoscopic hemispherotomy and endoscopic corpus callosotomy. Now, this was a patient who came to us in 2002. Patient came in status unconscious. You can see the front incisor missing because the child was intubated, was having 200 to 300 seizures. And that was the first hemispherotomy which I had to perform by reading the book and talking to some of my colleagues. And then soon we published our first paper in Neurology India on hemispherotomy. In 2015, this patient came as completely normal as a young adult. And our neurologist, my wife, keeps this photograph on a table because it reminds us of our first patient. And then we decided to develop an endoscopic technique because I was never convinced about such large hemispheric resections. So that is where we developed an interhemispheric approach. So rather than going in the typical Delalan's way of going vertically, we chose a frontal trajectory because here we would find lesser bridging veins. And we developed a technique of doing this from an opening which is just 3 into 4 centimeters, and the endoscope which was attached to a robotic device. So just to show a few examples, this is an hemispheric cortical dysplasia. You can see this beautiful disconnection which was done through an endoscopic route. Now this is an hemimegalencephaly, which frontal lobe, frontal horn aplasia, one of the most difficult pathologies to operate. And I operated this in Malaysia. He was having about 200 seizures a day. Again, done endoscopically, we lost just 40 cc of blood. And you can see this very nice disconnection, which was done almost without any blood loss. And these are some of the papers which we published on our endoscopic technique. Now, as a caveat, we then published the series of endoscopic corpus callosotomy, where we combined it with an anterior, posterior, and a hippocampal commissurotomy. Now, posterior commissurotomy, we did it for the first time in the literature, even though Professor Glure was doing it early in the literature, but they had given it over a period of time. And we do it for the cases where patients have severe Lennox distort, and we found that it gives almost 100% relief of drop attacks and significant reduction of other seizures. So we've always done a complete endoscopic corpus callosotomy. So let me try to show you this short video of endoscopic hemispherotomy. So this is the opening which we're doing under endoscope. It's magnified. That's the reason you don't see the ring around it. So you use extra long instruments going into the interhemispheric area. And that's the corpus callosum. These are the two A2s. That's the splenium, the corpus callosum. We first start with the division of corpus callosum, going back from anterior to posterior, backwards going to the splenium. And then again going back to the genu. Now this is the A2s curving around the genu, and this is where we start the anterior disconnection. It goes right flush up to the anterior cranial fossa till we see the olfactory nerves subpially. And then we start the middle disconnection, which passes in a parasagittal direction, connecting the anterior and the posterior. And it connects the ventricles with the temporal horns. And then, And then finally, we do the posterior disconnection, which is a short disconnection just behind the atrium, which disconnects the efferent, which disconnects the temporal efferents, which are going backwards. So using this, we found that both endoscopic hemispherotomy and corpus callosotomy were safe, effective, and minimally invasive techniques. And we managed to have 79% class 1 at 14 months. And we also described repeat surgery because we described a residual temporal stem. And by handling the temporal stem, we were able to further increase the success rate to 90% because doing a repeat surgery was a very straightforward. We published a paper also on that. So here we wanted to evolve further, but then we understood you need to really have an out-of-box thinking that a smaller endoscope cannot make it more minimally invasive. You have to think of something totally different. because I still felt that endoscopic technique, I have done more than 1,000 endoscopic techniques. And I feel that it's not a cup of tea for everybody to do this. It would require a significant learning curve for anybody to handle the endoscope, particularly in that narrow area. So we wanted to develop a technique which everybody could do. And that's where we developed our robotic radiofrequency techniques. So we started using it for hypothalamic hematomas. As you know, it causes elastic seizures. So that's a child presenting with elastic seizure. It's a typical symptom with this patient's present. And you could have various techniques. Now, you could also have we preferred a radio frequency ablation because here you could pass multiple trajectory and you could really carve out the entire lesion where you could do a disconnective ablation. Now, this is as compared to a laser interstitial ablation, where I believe you can introduce only one electrode. And even when you burn, there would be areas which are over-treated or there would be areas which are under-treated. And similarly, when you do an SCG guided radiofrequency ablation, thermocoagulation, again, it would not treat some areas. So we used bilateral techniques of disconnection for hypothalamic hematoma. So you can see we burn at the connection between the normal structures and the hypothalamic hematoma. So we could leave out some of these areas. And you can see this is a giant hypothalamic hematoma. And we were able to, we had to do surgeries maybe up to 3 times. But if you look, the second and third surgery becomes relatively straightforward because all these cases are done through a twist drill. And we were able to, with third surgery, we were able to attain almost 93% good outcomes. These are some of our papers. And then at this point, you realize that you do get a sense of doubt whether you need to proceed further or would you like to go back? Because after some time, when you get a certain degree of reputation, you're afraid to lose it. So every time you have a mistake or you commit a mistake, the sense of apprehension grows because now you have your reputation to protect. And that's when you feel that let us again retract back safely into the original position rather than to search in the maze. But then you realize that sometimes it's safer to search in the maze than to remain in a cheeseless situation. So that's when we developed the technique of robotic thermocoagulative hemispherotomy. We call it ROCH because ROCH also stands for a small bird. And what we did we did some intelligent planning and we did a radio frequency ablative hemispherotomy, which disconnects. So we created from a hole, we were able to produce hemispherotomy just with a line. And this was completely bloodless. And we have done about 35 cases till date. And currently we use the X technique. So by X technique, through a single twist drill, we can pass multiple diverging trajectories by which we can create a hemispheric disconnection. So apart from the single hole, we need 4 other twist drills for ablating the corpus callosum. But the entire hemispheric disconnection, now we do it actually through a single twist drill using the X technique. So a few examples here, you can see the beautiful disconnection. And again, another patient of Rasmussen who was having, of course, the number of burns were initially large, but using X technique, we were able to reduce the operative time by 50%. Now, this is a child which we operated when he was 5 months old. And then there was a little bit of connection. We had to do a repeat radio frequency ablation. And then there was this flap. So we decided that if you put a probe here, it would only push the flap. So all we had to do is put an endoscope and then disconnect this flap, following which the child became seizure-free. So child came recently for follow-up at the outpatient, was 4 years old and totally seizure-free. So I'll just show you the technique of ROCH. There's nothing much happening. You have a robotic device, you put an adapter, it goes flush with the skin, no incision given on the skin. You drill directly through the skin. Then you coagulate the dura. And then you pass the probe to the trajectory. So the planning is the key. And then you have number of markings. So you go on burning with an interface so that you're able to cover the entire area. So the most important thing is planning. So each burn is made. So we also fuse one of the trajectories with the OM and MRI to ensure that our trajectory is good enough to the target, but not for all trajectories. And then once we remove, the glue is injected so that there is no CSF leak. And you can see there's absolutely no blood loss. All you have to do is just put sutures and put some band-aids, and that's it. So we have done it in 35 cases from all spectrum pathologies, and we have been able to get about 80% good outcome. We are in the process of writing our second paper for this. So it takes a long time, relatively long time. It takes us about 5 to 6 hours to do this technique, but at the end, this is how it looks like. So the only thing is the resident is totally bored because you have taken away a very beautiful anatomical surgery away from the resident. So most of the surgery is just burning and nothing much happening, either for the surgeon or for the anesthetist, because there's no blood loss and everything. But the best part is obviously from the safety perspective, no blood loss, single sutures. If you require, you can easily stage it with a single twist drill. And it's there in the chapter of Pete Ingles' textbook. You could read about it, chapter 219. So we could think that we could thump our chest thinking that we have made some progress, but I feel that we are still here. We have just learned how to grapple with our instruments. I think we still have a long way to go. That's how I feel about it. Now, a caveat to this was a standalone corpus callosotomy. So this is a 10-year-old male with Lennox distort, multiple anti-seizure medications, multiple semiologies. And so this is part of hemispherotomy, but this is for a standalone corpus callosotomy. And I put it here so that you could see how the corpus callosotomy is performed. So we use 4 or 5 oblique trajectories in order to do a standalone corpus callosotomy. And you can see we actually burn to one side, not exactly in the center. So this is something you can actually start doing immediately because it's a very relatively more straightforward and a easier technique. And we have done it in about 5 patients till now. And drops have stopped in all the patients, and there has been a reduction by about 50% in other kinds of seizures. Now, developing our SCG program was a challenge because most of our patients have to pay money out of their pocket. So we wanted to catch hold of low-hanging fruits. So what we did is we decided to go only for those cases where we had a reasonable index of suspicion based on the non-invasive investigations. And we just had to prove the hypothesis. And we have done SCG-guided radiofrequency thermocoagulation in all the patients. So in the step 1, we put the SCG electrodes, we do a recording so as to capture 3 habitual seizures. And then we do stimulation both in the low frequency and high frequency, and we try to produce the habitual seizures bedside. We also call the patient's attendants to confirm that whether this is a habitual seizure. And then step 3, we do an SCG-guided thermocoagulation using this composite switch box. And this is how it looks on egg white. And we do it in awake condition because it's totally painless. The only thing is the patient would hear a pop sound in the head, which could also be auscultated, and that has to be counseled. But otherwise, all our patients have tolerated it very well. And after this, even if the seizures are not controlled based on the hypothesis, we go in for a surgical resection. So in this case, you can see that the MRI and PET were normal, but the ictal spect and MEG localized it to the left temporal area, and hippocampus was spared. So when we did an anterior temporal resection, we found that there was an improvement of electrocorticography, but when we removed the amygdala, it normalized. We find electrocorticographic guided resection following SCG very, very useful because most of the substrates that we are targeting with SCG are actually subtle cortical dysplasias, which have a typical signature pattern on electrocorticography. So that's an example showing we had a localization to the posterior part, but the final resection we did guided by electrocorticography. Now, this is a 36-year-old male who was having seizures since 16 years, and he was having aura force thoughts. So force thoughts with MRI normal would localize it to the frontal area. So ictal spect showed bifrontal localization, whereas the PET showed a temporal localization, which again had a correlation with the magnetoencephalography. And we put electrodes, 9 electrodes, and we found that the onset was from the right hippocampus. So we just did a SCG-guided radiofrequency thermocoagulation of the right hippocampus. So currently patient is still class 1 at 32 months. But if patient has seizures, we will again not hesitate to do an open surgery for him because we know where the networks are localized. This is another example of a 20-year-old female who would have a déjà vu with behavioral arrest with localization to T3 and T5. And MRI showed evidence of periventricular heterotopia with bitemporal hypometabolism, which was again concordant with the ictal spect, whereas MEG was kind of going to frontal. So again, we localized it to bilateral PVH. So PVH is one of the cases where you can have very good outcomes with SCG-guided radiofrequency thermocoagulation. So we thermocoagulated both the periventricular heterotopias, following which patient till now has been class 1 at a follow-up of 22 months. So overall, we find that only with SCG radiofrequency thermocoagulation, we've been able to attain about 22% seizure-free outcomes. But when we combine it with the surgery, we have been able to increase the overall outcome to 52%. So, and these are the cases, most of them are MRI negative. And you can see that about 53% of them are MRI negative. And 37% even, 37% were MRI negative. And I'm sorry. So these are the outcomes of MRI positive versus negative. So you can see whenever the substrate is positive, you have a better outcome as compared to those cases which are MRI negative. So at this point, you have to stop feeling afraid. So some wise man said that to overcome fear is to let it consume you, burn you, and finish you. And only then you stop being afraid. So my darkest corner was to set up a research lab, because that was an area where I had absolutely no experience. And then and we wrote up this research grant for almost 2 years, submitted it to the Ministry of Science and Technology with the help of Professor Gary Mathern. And then we finally got it. And we created 4 arms. One is the MEC Center, other is a clinical electrophysiology lab, an epilepsy surgery facility, and the first of its kind of neurobiology lab for India. I was quite hesitant to do it. Then Professor Tandon, my mentor, told me this sentence. He said he too had a dream, but he was fortunate enough to have people who could fulfill it. So he asked me to find people who could fulfill it. And then I was very fortunate enough to get these people who are really accomplished researchers, PhD students who came forward. Now, for the next few minutes, I will just show you the papers that they have produced. We have given them material, but they have produced. So this is the first of its report of transcription of selected brain samples. And this again, a study on proteomics of cortical as well as hippocampal tissues. And this is a mass spectrometry based targeted metabolomics for lipidomics, etc. Then these are looking at altered synaptic activity dysregulated by CDK5. And again, we looked at the regulation of glutamatergic and nicotinic receptors in epilepsy. And these are region-specific mechanism of hyperexcitability. We looked at them. And then this is a multi-omics approach for identifying molecular mechanisms of epileptogenesis. And this is a mass spectrometry-based brain lipidomics of high and low spiking tissues. And then again, looking at mechanisms of hyperexcitability. This is a comparative transcriptomics for peritumoral areas. This is electrophysiological investigations of mechanisms of hyperexcitability. This is again looking at the dendritic reorganization in rodent models of status epilepticus. It's analysis of again drug-resistant related molecules. Then we again looked at various neuroinflammatory dysregulation. Then we also described canurenic acid as a potential biomarker for hippocampal sclerosis. We also got it patented. Then we developed an AI algorithm using EEG to see the onset of seizures. So using this algorithm, you can see that the onset of seizures is actually from temporal, but the patient presented with frontal semiology because most of the activity was from the frontal, but the original was actually from temporal, which was again, when they went back to the video EEG, they confirmed that it was from the temporal. We created this EpiNet collaboration with Asian Oceanic Epilepsy Congress with International League Against Epilepsy. This is a register for the entire Asian region. Now we are recruiting centers from Asia so that we could have a huge database from the entire Asian and Oceanic area. We also tried to help other places to develop their own epilepsy surgery programs, and these include Indonesia, Morocco, and various other countries, and as well as various other regions from our country. So by this time, you would know that cheese is a metaphor for what you want in life, whether it's a job, relationship, money, a big house, freedom, health, recognition, spiritual peace, and even an activity like basketball or running. each of us have an idea of what cheese is, and we pursue it because we believe that it makes us happy. And sometimes when we lose it, it could be traumatic. And maze is where we spend our time looking for it. It could be an organization where you work. It could be even relationships, what you have in life, or the community where you live in. Sometimes the corridors and chambers, they contain delicious cheese, and sometimes there are dark, blind alleys, and sometimes there could even be dangers in some alleys. Now, in the book, they speak about finding an utopian place, or finding a closure, or finding a place which was full of cheese. But I think in reality, there is never a closure, because the search for cheese never stops. The maze never ends. It changes, it transforms. There is always new cheese to find. I think the joy lies in searching for cheese. So, what is a new cheese that we found which is suitable for this part of the world? It takes time to find new cheese, and with the team, it becomes easier. Do not depend completely on what travelers tell you from other places. You need to choose your own path. However, taking advice is very good. So in our case, we developed good protocols for MRI, which was very useful for us. We tried to maximize our non-invasive investigations. We created minimally invasive strategies. We created some bunch of randomized controlled trials from our region. We also are collecting actively data, and we hope that we can collect a very good database for the entire Asian region using the EpiNet platform. And we feel that it's very important to create very good research platforms. And talking about maze, so these are the relationships in which we have invested in, like to acknowledge such a quantum of work would not be possible by a single person. So I'm more like a spokesman, speaking about the work which has been done by a lot of other people, Dr. Ramesh, my colleague, and of course, Manjari, who leads the team. Dr. Aparna and Dr. Banerjee are the lead researchers for our research labs. Both of them are NIH trained. And these are our research staff, and these are the funding agencies. And of course, this is a maze where I've been searching cheese now for more than 25 years. So with this, I'd like to end my talk. And thank you once again for giving me this opportunity. I hope I've not short my time. It's just about 6 p.m. Thank you once again for this opportunity.
Thank you so much for that amazing tour through your career and in terms of tracking down ideas and having the courage to experiment and figure things out. And can you talk a little bit about, you showed us a lot of successes. So did you have any, for lack of a better term, cheese failures along the way? So were there ideas that you tried and you said, I think this is a great idea, but then realized it wasn't? I think we lost your sound.
Yeah, sorry. So yes, we did have a significant number of failures. They're bound to happen. So if you look at holistically, we had a lot of challenges trying to set up the epilepsy research lab, because that is something which the funding agencies were initially not convinced upon. And it took a lot of time for us to get the right team together. And for me, the biggest shortcoming was that I don't have a research background. My area of competence is clinical, and that's what I've been doing most of my life. But then again, things have fallen into place. Yes, we do have a number of epilepsy surgery failures who do keep on coming back to us. We have some frustrating cases where we find that we are not able to get any hypothesis, and these are the patients who continue to have seizures day in and day out. And we have discussed these cases with a lot of experts, and we really don't know what to do about these cases, because every kind of investigation is negative. And I'm sure every center have this bunch of cases where you can't actually do anything much. You change your anti-seizure medications, you try ketogenic diet, you try to do something else, you don't get, you do a corpus callosotomy, it doesn't help much. Then you try to do a VNS. So I'm sure these are there for all the cases. And then there are also, you become more wary of complications as you age. You can tolerate complications when you're younger, paradoxically, because when you get older, you have a reputation to keep up. That could again impede your growth. So and I think the most difficult thing about epilepsy surgery is that you cannot walk alone. You need to walk with a lot of other people. And that sometimes can be very trying and very difficult. But if you manage to do it, it's really satisfying. I mean, I'm just trying to put it in a bird's eye perspective of the kind of challenges we faced.
See what questions people have.
Thank you so much for such a wonderful talk. I find the radiofrequency hemispherotomy, very compelling, and I think in many ways a very brave undertaking to advance the field. And it seems natural that this is the direction that things should go: robotics, stereotactic ablations. But you yourself have said that you think that this is still in a somewhat early phase. The tools themselves are fairly rudimentary. I mean, radiofrequency ablation has been around since the 1950s and 60s, very small diameter burns, and you need to make many, many trajectories, passing them each through the brain. So I'm curious, as you look out ahead now, what do you think, if you have unlimited resources, what would be the ideal tools that you would want to be able to advance this? Is it an MRI compatible robot so that you could do laser ablation? Does the field of focus ultrasound need to catch up to be able to make this many ablations? Where do you think the innovation is gonna happen next?
Great, I'm so glad you asked this question. So the thing about radiofrequency ablation is that it's been used in thousands of patients. But unfortunately, there has been no much development in this technology because I believe it doesn't give much returns for the companies. So you make a radiofrequency device and you sell it, that's it. And you could go on using it in thousands and thousands of patients. Our robotic guided radiofrequency ablative hemispherotomies costs patients only $30. That's it. It would be the cheapest and the most minimally invasive hemispherotomy ever on the planet. Because there are no consumables. You just need a radiofrequency machine and the robotic to guide, and you need to do some intelligent planning. So over here, definitely there is a lot of development which we could do. Firstly, we could create electrodes. You could have the radiofrequency burning electrode, which could have multiple burning points. So you don't have to actually move the electrodes. And I think this could be one of the first of its kind of surgery, which could be completely AI driven because the learning curve is practically not there. The entire surgery is only in planning. The execution is absolutely not there. What you're doing is you're just moving around the robot and you're just burning. That's it. The surgery itself is extremely boring. We had a couple of very senior neurosurgeons coming from Israel, and they wanted to see this technique, and they finally realized that the entire thing about the surgery was only planning, and the surgery itself was so boring that they couldn't sit there more than it's just a same just go on burning. There is no blood loss. So I believe it could be completely created AI driven. So you could plan out completely and then you could come to a point, but then you need to have those industrial, those commercial invest into this. But unfortunately, nowadays, people are more interested to invest into healthcare where you can get a lot of profits. So they want to invest into articles which are consumables. So you want to invest into electrodes which are one-time use. And that's the way the companies run. I mean, I'm not blaming them, but there is a very exciting possibility where this could be completely automated. Now, speaking about laser, the problem of laser is that it's the greatest advantage of the laser is actually the biggest shortcoming for hemispherotomy. Because when you do an hemispheric disconnection, you're going through a more or less completely avascular area. So that hemispheric disconnective area is more or less completely avascular. The only vessels you encounter are the lenticulostriate. That's it. And those are really small vessels. And when you use a radiofrequency ablation, you have an area of penumbra around it. So you could give a very good overlap between each one of them at the penumbra region, which is not possible in laser because it's pencil precise. And so you would have to do many more lasers. I do realize that there is a case report of laser hemispherotomy, and it will be interesting to see how it develops. The other shortcoming of laser is that I believe the current technology, we don't have laser in India, and this is, I mean, you would be knowing this better. But the current technology is that it's all MRI compatible and plastic materials. So once you put it, you have to shift him to the MRI, you have to shift the patient to the MRI suite, and then you're burning the laser. And then for a fresh trajectory, you have to bring back the patient and again redirect. So that's not going to work here. So if you have to develop a laser technology, the whole thing has to be totally, revisioned, reinvented, and completely devised in a completely different way. And that way it could work. But yes, our demonstration of radio frequency ablation shows the proof of concept. It shows that it really works and it's the most minimally invasive technique to actually do it.
I have a question, Dr. Chandra. That was a great talk. How do we balance in functional neurosurgery the using high technology and the sort of look mom, no hands development, with what we have is some very basic, very good and inexpensive operations that actually work. And I'll give you an example. Calisotomy for atonic seizures is a very low-tech procedure, right? Which is basically a craniotomy that, every decent surgeon knows how to do, which you can do in a couple of hours, But instead, now we've transformed it into high-tech, high-expensive, high technology, robots, lasers, all types of things. At what point do we start looking at a balance of this,
So thank you very much for this question, Professor Baltok, and thank you very much for attending my talk. So you're right, at some point we need to balance, but I think the most important question is it useful for the patient? That's the most important question. And is it really sustainable, particularly for this part of the globe? So we are able to do a radiofrequency ablation for corpus callosotomies. We have stopped doing an open technique. So we only use the twist drill. We pass a probe and we just do a radiofrequency ablation of the entire corpus callosum. And it gets over in about 40 minutes using a robotic device. And it costs the patient only $30 US. That is it. The reason is ours is a public funded hospital. So the robot is purchased by the hospital, and the radiofrequency machines, once you buy it, you can use it again and again. The electrodes, you can use it at least for 500, 1000 lesions. And the hospital doesn't expect us to generate a profit because it's federally funded. So that's how we are able to pass on the benefit. So the patient's cost is quite less. So we've been able to convert a high level of technology, make it very sustainable, and also make it very effective. And at some times we need to strike a balance, because every time you develop something new, you have to lose something. So when you do a robotic guided radiofrequency ablations, the residents have lost an opportunity to see an open surgery. They have lost an opportunity to see the anatomy, the beautiful anatomy you have of the corpus callosum, and they may never see. So my current batch of epilepsy fellows have not seen an open corpus callosotomy. The only thing they have seen is a robotic. And they plan to do it using a stereotactic frame because it's only 5 trajectories. But I guess that's how development happens, because the patients ultimately want a procedure which is not surgical. They want that you should not even touch the patient and the patient should be cured. So that, I think, is the ultimate objective.
Thank you.
Sarat, can I ask you to follow up on that one bit, in terms of, obviously as you're building these sorts of things, it's convincing everybody else on the buy-in of this. And particularly one of the things we have in the States is that, the FDA has not approved any device for lesioning for epilepsy in the brain without thermal monitoring. So you're using a Cosman generator and you have a lot of experience with that. So can you tell us, is there, have you had any sorts of problems whatsoever in terms of lesioning with not having thermal control? And how do you decide when your lesion is done other than with the auditory aspect of it? Like from your experience, how do we learn from that to make it safer if we don't have, thermal monitoring of the temperature where you are? Yep. May have lost him.
Good question.
We're almost condemned to the MRI because we have to monitor, right?
No, I mean, I think, we've started doing radio frequency ablation through SEEG electrodes in the EMU. And
Mm-hmm.
there's no reason that we couldn't do and look, other places, Mayo, Emory have been doing bedside ablation using electrodes. And obviously, you've got lots of experience of prior lesioning for movement
Sure.
disorders, right?
Yeah, movement disorder, it's like that's where it came from, you know?
Yeah, I'm not even sure we still have a lesion generator.
Yeah, absolutely. And now people have moved to doing that with lasers because they're scared to do it with radio frequency, that they're worried about all those issues.
There we go. Oh,
I'm sorry, I lost you.
yeah, it's okay. So what my question was, I'll abbreviate. My question was, the FDA here is very hung up on having thermal monitoring when you're doing lesions in the brain. And so we don't have an approved indication. So we could do what you're doing off label, but in a medical legal climate like New York, people are a little nervous. And so are there any issues that you found in certain circumstances where you've had problems making size of lesions? How do you determine when you're done with each lesion? Is it all based on timing? Are you listening auditorily for the pop? How are you determining the extent of lesioning?
So Guy, that's an excellent question. So you're asking two things here. One is about the SCG guided radiofrequency thermocoagulation. So that's quite well established. There are a lot of centers in Europe who do it. Now, talking about the radiofrequency ablation, which we have described for hemispherotomy and corpus callosotomy. So what we have found is whenever we do it for non-atrophic cases, it's fine. You have a lot of atrophy, you have a lot of cavity. But whenever you do it for non-atrophic, like a hemimegalencephaly or so, the edema is maximum on day 3. So we cover them with steroids for at least 5 to 6 days, repeat a CT scan on day 3. And then after day 4 or day 5, the edema settles down and the patient is quite okay. Now, in my series, if I would have presented only the robotic hemispherotomy, I would have shown you that we have had one mortality. And it was a small child who had a large hemimegalencephaly, and he had a deep venous anomaly, a very large deep venous anomaly. So we were very aware of this deep venous anomaly and we avoided it. But unfortunately, the heat reached to the venous anomaly and there was a very severe brain swelling and we had to do a decompressive craniotomy. But the child did not make it. So that was a mortality we had in the recent times. So we are a bit careful about doing it in hemimegs. But otherwise, we are very comfortable doing it for all Rasmussen's and all the hemispheric cortical dysplasias, as well as for all the atrophic cases. And in hemimegs, if we have to do, we will examine it very carefully to see that there are no gross anomalies so that we can have a complication like that. So that's the only issue we had. But otherwise, we have found it to be a very safe and a very effective procedure. And we had to take the ethics clearance from our own institute before we started doing it. So we initially took it for 1 or 2 cases. And when the patients were doing well, they gave us the clearance to go ahead and do it as a study, based on which we have done this. We published the initial paper, and now we want to publish the series of 35 or 36 cases that we have done. We have found it quite satisfying and kind of replaced the open hemispherotomy. We do open hemispherotomy only when this has failed or we need to put in an endoscope and do some kind of disconnection and all that. But otherwise, we don't do an open hemispherotomy anymore.
I think, as you were saying, and as Brett was asking about, with the ability to use artificial intelligence to plan trajectories and with how minimally invasive, as much as surgeons don't like it because they love the operation, it's like radiofrequency or laser ablation for hippocampal sclerotic mesial temporal epilepsy. I mean, those cases, unfortunately, are as a surgeon are going away, but that is the trajectory of the field. And I think no matter how reluctant people are, the field is headed your way.
That's true. That's really true. And I hope it happens as fast as possible.
Any other questions, anybody? Sarat, thank you so much for spending your time with us today and filling us in on your journey for cheese across all the different specialties. And really, we look forward to talking about this more with you.
Thank you so much.
Thanks for a great talk. That was wonderful. Thank you very much. See you in China.
Yes.